But motivation is a real issue, isn't it? Because I know a lot of my patients with breast cancer, they're just, we're hitting them with chemotherapy, they've lost their hair, they're gaining weight, they can't sleep at night, and then you say to them, look, you've got to start doing some brisk walking.
Yeah, it is. I think two points in our experience with our exercise clinic for cancer patients is the first one is that it's the hardest part is to actually make that decision and that commitment and to get there. But we do then experience that positive feedback that comes to you where you actually feel better. Your nausea is reduced and your fatigue is reduced, and it starts to perpetuate itself as you get those very positive feelings that come out from that. The other thing is that it needs to be done in a supportive environment where your partner or your carer gets involved with that, with your exercise program, and there's great spin-offs. I think we're seeing with the great demands on the carer network is they often fall into ill health. And it's very, very important for them to keep up their physical exercise and their nutrition and their meditation, because if their wheels fall off and they develop a chronic disease, then who's going to care for the patient? And then you've got a carer to care for the carer. So we try to encourage, and we see this a lot where a mother and daughter may come along to our classes, or a wife and her spouse will come. We see a lot of siblings coming together, sisters turning up, and they both get benefit, but it's that motivation. Then when they get in and they're in a large group situation with people in a similar situation who are going through chemo and radiation therapy, and you're exercising together, and that becomes a strong motivating effect, and a group cohesiveness develops from that.
Support they get from exchanging.
Exactly.
Right.
A lot of these changes are really difficult to make by oneself, and I think that I'd just like to emphasise that that getting your close family or friends involved, or being in a support group situation where that's part of the program, makes it a lot easier to get started and then to maintain it. So I think that the context, and also in health coaching, for example, in terms of changing motivation, sometimes it's really good to sit down with something in front of us and say, all right, well, look, let's look at the balance sheet. What am I getting out of not exercising? No effort, and don't, avoid the cold, or whatever it might be. I don't get, sort of aching muscles, after a workout. So we might have sort of a balance sheet, but what do I get out of exercising? And sometimes we're not in the conversation with the healthcare practitioner, we realise, well, actually, there's a lot more on that side of the balance sheet than we realised. And so then it starts to become a little bit more of a conscious choice rather than just a guilt trip of, oh, should I, shouldn't I, do I want to or don't I want to? It starts to become a little bit more of an informed decision. And so that might be a useful thing to look at.
Kim, you've got a comment as well?
I think Rob made a really important point, that it's incumbent upon health professionals to get the message out there that's really a bit counterintuitive, that the cure for fatigue is exercise, because the common sense approach is if I'm tired I need more rest. And so we really need to get the changed mindset out there that what's going to really improve your fatigue is exercise.
Yeah. We've got about 8 to 10 minutes left, so I might just get back to James.
Question is from Geelong in Victoria, and the person's asking, as a cancer sufferer, do you have the right to the end of treatment? And if so, can you make that decision?
James, can you just repeat that again?
As
this piece is affecting my hearing, I think.
As a cancer sufferer, do you have the right to say that you've reached the end of your treatment? And if so, are you the person to make the decision?
Okay, so the question is related to what are the exit rules for active treatment, I presume? Maybe you must see this all the time in medical oncology.
It's every consultation for someone who's having palliative treatment. It's whether that's supportive care alone, or whether palliative treatment includes radiation therapy or chemotherapy. It's not a static picture. It's a fluid situation. So every consultation, you're weighing up the pros and cons of continuing treatment or not. So of course, if you feel that a patient felt that they weren't benefiting from treatment, they should discuss that with the person providing the treatment, and the treatment can be ceased.
Okay. Any other?
Can I just ask a further question to that? So if that decision is reached, where does that person then get their medical support? I mean, is it just back to the GP, or having ceased treatment, can they still come to their oncologist for monitoring or whatever?
Absolutely. So I think absolutely they can still be involved with their cancer specialists, their oncologists. The emphasis does change, and so the general practitioner, palliative care team, palliative care nurses, other health professionals probably come more to the forefront. But absolutely, in a lot of centres, the medical oncologists and radiation oncologists are still involved in that symptomatic care.
But I presume in the rural and regional areas, we don't always have coordinated palliative care teams, and the GP is a key, and the oncologist is still a key.
Yeah, absolutely. So unfortunately, one of the findings in the COSA report is that not all Australians have access to a palliative care team, and a lot of palliative care teams don't include a medical professional that's identified as a palliative care specialist or a GP with an interest in palliative care. So the GPs are really integral in the more remote areas at that stage of the patient's journey.
Okay, next question. Sorry. Did you have a comment?
Yes, look, if I could just make a point, speaking from a personal point of view, I spoke a lot with the oncologist that I finally chose and went on a course of chemotherapy, and in constant discussion with him, I sort of said, look, he was proposing another 6 months, and I said, look, why? And we talked it through, and I said, well, I think I'd sort of like to end it at this point. And he was totally supportive. He said, well, if that's what you believe, what you feel, he said, what you're doing outside of chemo appears to be working for you, and he was most supportive. Now, although his treatment for me ceased at that point, I was still going back to see him every few months with blood tests just to discuss the issue. So while he was not playing any direct role in my ongoing treatment, he was there in a support role.
And I think having an understanding that medicine isn't black and white like that, that is 6 cycles really better than 4 cycles chemotherapy and so on. It's always a cost-benefit analysis in terms of the pain and the gain. James?
Next question is from Ballarat. What are some of the early signs of post-traumatic shock?
I think...
For Kate, I think.
Kate spoke about that.
I think basically, if you think about the symptoms of depression and anxiety, and that they are pervasive and become quite debilitating. So things like pervasive sleep disturbance, change, loss of pleasure in simple things that normally would have given you pleasure, very basic things, hard to get out of bed of a day, lacking motivation. But it's about the severity and the pervasiveness of it that is most important as an indicator. As I think Kim highlighted earlier on, anybody that has ongoing concerns around feeling sad, overwhelmingly sad, that is, not having a blue day, because fortunately we all have those, they help us enjoy the good days. But something that's ongoing certainly should be go and see your general practitioner as your first point of call.
Any other comments from the panel on that one?
It's not a diagnosis one makes of oneself. It's a hard diagnosis to make even by the health professionals who specialise in that area, and as well as being characterised by the normal symptoms of depression, there are additional elements such as flashbacks and the experience of trauma. So if you've ever been through a traumatic event like a major car accident or something like that, similar to that. So I think be alert to those early signs. If they're not resolving with the usual supports and interventions that have helped you get through things in the past, then you do need to be assessed by someone who's expert in that area. And I think you'd need to go first to your GP or to the cancer centre.
Next question is from Esperance. Whilst I appreciate the massive investment in research for cancer cures, I consider it imperative to have an intensive screening program for more of the most common types of cancers. What are your views on this? Directed to you, Professor Boyages.
Oh, to me, well, as a former breast screening director, I think early detection is very, very important, and I think we are getting better in Australia in terms of rolling out a colorectal screening program now. Prostate screening, there's a lot of pros and cons about that and so on, and obviously the success of the cervical screening. But yes, screening is very important. I know in the USA they're beginning to look at lung cancer screening with these high-resolution CAT scans, but there's a lot we don't know, and we know that screening means screening a lot of normals to find the very rare abnormal. But
if I could just add as well, I mean, even less resources very often go into primary prevention, and best of all, I think, would be to be investing in community programs to do what we can to prevent the thing before it even happens, and then to look at screening, and the earlier the intervention in the process, then the better the outcomes, I think.
Those dinosaurs should have stopped smoking, really.
I'll jump on that one as a bit of a political hobby horse, but the World Health Organisation estimates that if we were to address the 3 risk factors for chronic disease, being physical inactivity, inappropriate nutrition and tobacco smoking, that we could reduce the incidence of cancer by 40%. And yet, in terms of the NHMRC, for example, which is the main funder of health research in this country, only 6% of its total budget is directed towards preventative health research.
I think we've actually gone to the end of time, so that may have to be the last question. But is there any other comments? I think, Craig, you're going to...
oh, no, I was just going to add to it's already been covered.
It's already been covered.
So, yeah.
But I think prevention, early detection, good treatment, surviving cancer and looking after yourself have all come out as themes. So, look, I'm really sorry we have to make that the last question. And that's all the time we have today. If you have any unanswered questions, please look at some of those websites that have been mentioned. Go to your Cancer Council sites and go to the links as suggested. Go to their helplines, and of course there will be a DVD available, and we'll work out how to make that available. If you're planning to introduce some of the changes presented today to your lifestyle, please talk them through with your doctor and health professionals first. It's important to always look at this whole message of integrated care rather than saying I'm going to go only this way or only that way. There is a evaluation questionnaire. Please remember to fill this out, as future events will be shaped by the very important feedback that we get from you, our national audience. And please hand in your completed questionnaire to the coordinator after the session. There are obviously so many people to thank today, and I'd like to thank everybody for taking the time to attend this information session. I hope this has provided you some useful information and perspectives to assist you and your family as you cope with this, I guess, tragic and dreaded disease that faces so many Australians today. There are some special thank yous, of course. I'd like to, could you please join me in thanking our speakers who've travelled from all over the country. Thank you for the content, the amount of research you've done, and telling your personal stories, which have been very important. And thank you to Craig and James who've joined our panel to make that a success. I'd like to make a special thank you to our steering committee that has worked tirelessly to develop this session. You played a vital role, and this information session would not have been possible without your commitment and support. And so thank you very much again. You know who you are, all those people who have given hours and hours to make this happen. Also to the coordinators who have done a great job to get the show on the road across our 58 locations all across Australia. And thank you also for your hard work, dedication and your time. Also the hard-working nurses on the phone and fax today who've taken a huge number of questions, and I'm sorry again we couldn't get to all of them. And on behalf of the steering committee, just a very, very special thank you to Roche Products who've invested enormously in terms of both financially and time to make this possible to the cancer community, and for basically their sponsorship to the program. Thank you also to Sky Channel for their technical expertise today and Edelman, who have worked with Roche to ensure a very smooth running of this event. So, in closing, we hope you've enjoyed this information session, Surviving Cancer in Rural and Regional Australia, and I hope you have a very good weekend. Goodbye.